So our next talk is on difficult corrosive stricture, intraoperative decision making by Dr. Dipankar Roy.
Good morning, Chairpersons. Good morning, everybody. I think Professor Inian had explained nicely of the basic principles of difficult corrosive strictures. So what's a difficult corrosive strictures? In general, the more high up the stricture we all know is the more difficult to manage. If there is associated laryngeal injury, facial burns, extensive pharyngoesophageal scarring, that's more difficult. Apart from that, we may have to deal sometimes anastomotic stricture following pharyngocolic or esophagocolic, corrosive stricture with tracheoesophageal fistula, or anastomotic stricture with fistula. Those are a bit of difficult strictures. We all know that patients' difficulty, they are mostly malnourished, few of them anemic, they may have poor cardiac respiratory reserve, psychiatric disorder, previous neck or thoracic surgery, or diseased colon. Now, I'll skip this. Basically, if it is isolated esophageal, first line management is dilatation, replacement or bypass if it is not satisfactory. Isolated short gastric stricture can be dilated, but most of them need surgery. And if it is in combined, the patients are more malnourished and need something. Before we do surgery, the patient should be optimized. Nutritional assessment, anemia corrected. They should be stable psychologically. Professor Inian already explained very nicely extent of stricture assessment. Distal assessment can be very difficult. Assessment of airway, lung function test. One small thing, many of them acute malnourishment cause gallstone, so that should be ruled out. And CT angiogram or mesenteric angiography is not routine in few cases. And if you suspect colonic disease or an aged patient, so maybe colonoscopy. So as a surgeon, when you decide esophageal replacement or bypass, 5 things to consider. There was one inlet, so that the patient eat properly, conduit, whether resect or bypass, how the route should be, and the drainage. Now I'll skip this thing because Professor Inian has nicely explained mostly the pharyngoesophageal strictures. This can be high within 14 to 16 centimeter of incisors or a bit of low strictures. This is also, Professor Inian said, if it is a very localized stricture, you can consider initial dilatation or initial flap followed by further. This is a more common situation where the pharynx and cervical esophagus is involved. Again, Professor Shastri also said that we'll try to dilate as much as possible before we do bypass. And this is something we need to consider permanent tracheostomy or laryngectomy. So in nutshell, one-stage colopharyngoplasty preferable probably if the healthy pharynx below the vocal cord is available. Otherwise, we should always go for step down. In practical scenario, if the pharyngeal dilatation is inadequate paraorally, or the stricture is so tight that you cannot put a guide wire, then explore the neck, consider pharyngostomy, at least you have an access for retrograde dilatation. And then you plan for an esophageal replacement at a later date. And Professor Inian already said, the swallowing difficulty, repeated aspiration, those are the problems of these cases. So once we tackle the inlet problem, the conduit dilemma, we have 4 options: gastric, sometimes reverse gastric, more in pediatric population, more common is colon, and few situations jejunum can be used. Gastric conduit is preferable because of good vascularity, pliable, most important, single anastomosis in the neck, but it's more ideal for low down strictures, 3 to 4 centimeters from cricopharynx. Initially, we thought if there is a stricture in the stomach, it cannot be used as conduit, but it has been proved that it can be used as conduit in case there is a distal stricture with additional gastric drainage. In fact, in those cases, the stomach volume is quite bulky and it is helpful. Whether it should be a wide or narrow is a debate. Usually the surgeon now use 4 to 5 centimeter wide. You may need to do some additional procedure to gain at least 2 to 3 centimeter of additional length. The gastric conduit should be on right gastric and right gastroepiploic vascular dependence, so preferably to keep both. Difficulty is not ideal for high pharyngoesophageal stricture. If there is fixity, scarred stomach fixed to the pancreas, it cannot be used. Compared to esophagocoloplasty, the anastomotic stenosis rate is a bit more and reflux is more problem. In general, whether it's a right colon, left colon, mid coloplasty, the general principle, the whole colon with supplying vessels up to their origin should be mobilized. At any cost, avoid injury to the marginal artery. Isoperistaltic is always preferable. I only think if it is a right colon or mid colon, then the advantage is the abdomen, you do a ileocolic anastomosis, which should be preferable than colocolic. Be sure that feeding vessel is not stretched or kinked and avoid redundancy in the abdomen. That's a big problem. Now, we all know about it. Left colon, ascending branch of left colic artery is more reliable, less anatomical variation, smaller diameter, so easy to take retrosternal. But you need accurate measurement, per-operative, intraoperative decision making. You measure from the neck up to the root of the ascending branch of left colic, and then you measure along the marginal artery, not along the colon. That's the important thing. And sometimes in older patient, diverticulosis can preclude this left colon. Right colon, if you can keep the ileocecal valve there, then it prevents regurgitation, it's an advantage. Ileum matches with cervical esophagus if it is used for anastomosis. In unfortunate situation, if you took up the conduit and devascularized, still you have the left colon option. But the problem is the higher variation in the vascular anomalies are more, and it's a bit bulky sometimes to take retrosternal route. Very few indication for jejunal conduit. Professor Dash is here. So free jejunal graft can be used in partial conduit failure and recurrent stricture at the pharyngocolic stricture, but not in routine procedure. It's already covered. I think risk of malignancy in the leftover scarred esophagus. I think Professor Ian said, we all know Professor Chandramohan, his last few years talk was a routine excision of left-sided sternum. And I think the excision of GF sternum should be done in all cases. As a surgeon, when you take the conduit up in the neck, you will be thrilled to check the perfusion. If it is a little bit of dusky, there are several methods, including ICG. Is it mandatory? Still now, not now. It doesn't give you absolute guarantee it's going to be leak, and it's a subjective interpretation. So you can use check for the perfusion of conduit in the neck. The last thing, but very important also, you put up the conduit and it should be drained. If the stomach is normal, you are lucky. If the stomach with antropyloric stricture there, even then you can put it in the stomach with additional gastric drainage. If stomach body is a bit scarred, you can use the jejunum as a gastrojejunospasty. But if the stomach is very scarred, very small, and it cannot be used, the colon should be put in the jejunum. It can be either loop or Roux-en-Y. Both are possible, so depending on the situation. So take home message, Inlet, either pharyngeal or esophageal or combined, should be adequate for wide anastomosis with the conduit. So preparation of inlet is very necessary. Usually pharyngeal anastomosis is done side to side, so should be as posteriorly placed. That is another important point. They all have problem with swallowing, and it has been studied that if it is more posteriorly placed, the chances of, the relearning of the swallowing process is easier. It can be stapled, but commonly hand-sewn single layer, and all conduits should be well vascularized, tension-free, and adequately drained. Thank you very much.
Any questions from the floor?
Hello, can you hear me, sir? Sir, I'm Dr.
Excuse me, organizer, can you have a look at the mic? Yeah.
Hello, I'm Dr. Praveen from Manipal Hospital, Bangalore, sir. I have a question regarding the use of stomach as the conduit in a very young patient in the range of 10 to 20 years, but the stomach on exploration looks absolutely normal. Only there is a long esophageal stricture. Because this patient is a young patient, should we consider doing a colonic conduit as it is long-term results are good, or should we even consider using stomach?
No, that's not true. The long-term results with stomach is also very good as a conduit. You may have a problem with the reflux and all this. Long-term conduit is, results with gastric conduit is quite good. If it is a esophageal stricture down in the, say if you have a normal cervical esophagus stricture down in the thoracic esophagus, and if the stomach is normal, then you should use it. Because this advantage is, the colon, you have 3 anastomosis. They are sick patient, ill patient, malnourished, and 3 GI anastomosis, and all has to heal well. I think everybody who is interested in corrosive patients, they all agree, there are very minimal chances of error in these patients actually. They are so fragile. If one goes leak or anything, apart from the neck one, or anything happen in the abdomen, this is really a problem. You cannot save the day.
Thank you, sir.
Excuse me, sir, as regard use of stomach, the problem in stomach, as you said, conduit is not a problem. The problem is it still produces acid, and after some time, we have seen it produces stricture, and also Barrett's transformation in long term. That becomes difficult for the next time to operate. Then you have to do some procedure again after a few years.
You mean Barrett's in gastric conduit?
In the esophagus that is left behind, when you anastomose, when you have, as you said, when we use stomach, there is a reflux in that, especially when you put it in the chest.
Agreed.
So there is reflux stricture, ulceration, and stricture because of ulceration, and later Barrett's transformation.
I agree, but I don't have any experience. Maybe Professor Indian. If you use a gastric conduit, later on formation of Barrett's in the cervical esophagus, I don't have any data or anything.
I have not seen it either. My question is, patients who have had a median sternotomy before, a CABG, and then developed a corrosive stricture, which route would you prefer? They don't like us to go through the retrosternal route because there is some vascularity of the heart involved, and you have the native esophagus left. Are you forced to do an esophagectomy and use the posterior mediastinal route, or would you consider a subcutaneous route?
Yes, this is the most difficult one. But as I said, if you consider esophagectomy, surgically this is more amenable, but the problem is the patient had a CABG. So in that patient, if you keep the operation time shorter, that is definitely advantageous. So I would definitely consider a subcutaneous route in that patient.
So just going back to that question on the use of stomach for the conduit.
Yes.
So basically, one needs to be very careful because most of the time esophagus and stomach injuries go together. So if at all you're going to use, even contemplating using stomach, just make sure that you wait long enough. Just make sure that the stomach is absolutely normal. Because if you have a long stricture in the esophagus, it's, there's bound to be some, injury to the stomach. So that's number one. Number two is, if you're using the stomach as the conduit, then with the esophagus left inside you, like if you're not resecting the esophagus, it's going to take a very long route to reach the neck, right? So if you're resecting the esophagus, then obviously you can use the stomach, and it's a shorter route to reach the neck. However, if you're not resecting the stomach and if you're contemplating using the stomach, then length may be an issue to consider.
That's why I said it should be used preferably in the low down. I mean, if the cervical esophagus is a bit normal,
Correct,
like that.
yeah.
It's more
So
of a thoracic esophageal strictures.
Yeah, it cannot be used for very high strictures.
Yes, definitely.
And thirdly, regarding Barrett's, esophagitis, yes, reflux. We have not seen actual Barrett's as such, but
yes.
esophagitis, yes,
It's possible.
is definitely
Definitely.
more common. Thank you.
I think I will add on one thing, Professor Inian will agree also. Few patients, before operation, you know the stomach is large, some barium trickled and you know the stomach is large. But as very long segment strictures where you cannot really assess how big is the stomach. So it's an intraoperative decision. Now there lies one more problem. It can be externally look normal, the stomach is nice, normal, dilated, but even then there can be some antropyloric stricture. So at least when you use that gastric conduit, from neck you should check either you do a pyloroplasty or staging or to check that there is no stricture down there. This can be externally looking normal, but there can be some bit of antropyloric scarring. Yes.
One comment and one question. The comment is regarding Barrett's. The risk of cancer in Barrett's is highly exaggerated. It's about 1 in 400. I do have a lot of experience on Barrett's. Developing Barrett's in the future is a completely non-issue, in fact, in these patients, as you both pointed out. So I wouldn't worry about that. The stricture, yes. Reflux, possibly, yes. My question, which is actually not been touched upon by anybody, and don't forgive me because I am actually not very experienced in dealing with corrosive strictures in the UK, is regarding the function, the long-term function, because these patients, if you salvage them properly, they can live for years. They're often very young patients.
Yes, of course.
My question is about function of the colonic conduit in the longer term.
Yeah, hello.
How do they?
I think the next talk is exactly on the same topic what you're asking.
Yes.
Yeah, one small question. What I want to, it is the intraoperative decision making. So most common problem what we or the budding surgeons will find is that the esophagus the colon once you take up, you are finding that colon is not reaching or it is not having a good vascularity. So what is your take on managing these patients?
If you from the very beginning selected left colon, then it's a real problem. But last few years, we are using mid-esophageal coloplasty or right colon. And I think one of the reason is, advantage there, we clamp ilocolic pedicle, we clamp middle colic pedicle, we mobilize everything and take up there and see if the middle colic can be spared. Sometimes you are lucky, middle colic spared, you are happy with the anastomosis. Even if the middle colic cannot be spared, you can still, depending on ascending branch of left colic. From the right colon side, if you take up in the neck, you have quite a bit of options to do. But it can happen even with that, if there is a vascular anomaly, which is that left ascending branch is not supplying up to neck. And in those cases, the concept of supercharging and all these things there, I have not come across. But over the years, I have found that for the juniors, this is in the left colon, you need to measure it. You need to be very experienced to know exactly how much colon you needed to put it. For the
I think you made a point. It is not the length of the colon what is important. It is the vascularity of the vessels which is to be measured at the length for taking up the colon. I think you made your point in your talk.
But
just to
in case of right colon, you have the option of even if there is some bit of devascularization in the neck after you put them, you can resect, you can sacrifice the middle colic, another 6 centimeter of colon will be available in the neck. That was my point.
One small point. When you said that the anastomosis in the neck has to be posterior to prevent incidence of regurgitation, what do you mean by that?
Pharyngocoloplasty.
Yeah.
More posterior.
Posterior.
There is a nice paper, it's an old one, just because of this talk I was first into. One of the famous cardiothoracic surgeon, Professor Shoibal Gupta, in 90s, this paper was published in BJS. It's a fantastic paper. He did a study on all pharyngocoloplasty, difficult strictures, what we are talking about. And all of them, he used his posterior pharyngeal wall, resect a bit of posterior pharyngeal wall and put the colon there. And he did swallowing study, he did manometry, he did barium, and the paper is around, I think 45 or something patients, and showed it, it's much better, swallowing is much better if you do it with posterior pharyngeal wall. So I haven't gone that far, I have not gone that far to exercise posterior pharyngeal wall, but place it as posteriorly as possible. That helps in swallowing.
Thank you,
Thank
Dr.
you, Dr.
Kar.
Roy.